These are my disclosures, same as before. So what I thought we should do is talk a little bit about pregnancy and HIV, outcomes in the era of art. Perhaps the most important bit about pregnancy and managing HIV in pregnancy is the prevention of mother-to-child transmission. Take a little look at art PK in pregnancy, look at some adverse events, and then spattered through the talk will be recommendations for managing art in pregnancy. So more than half of all people living with HIV globally are women, and about 10% of those are pregnant or breastfeeding at any given time. So on the UNAIDS estimates, at least in 2015, there were probably 1.45 million women who are pregnant with HIV around the world. This is the way the graph looks over time. Like I'd say, 10% are pregnant or breastfeeding at any given point. And this is our coverage of antiretroviral therapy amongst pregnant women for prevention of mother-to-child transmission. As you can see, even as late as 2017, 2018, 80% were on antiretroviral therapy to prevent mother-to-child transmission, which is nowhere near the 90% targets that we were trying to achieve for 2020, and nowhere near 95% targets we're trying to achieve to try and eradicate transmission of HIV from mother to children. In addition to that, we have seen this data over and over again, but if you are pregnant and have got HIV, your chance of dying in pregnancy are much higher than if you're not pregnant. And this is, global maternal deaths from 1980 to 2008. And you can see since the advent of HIV, the lines have started to diverge, and there's more mortality amongst pregnant women with HIV. So you all know that there are different phases in the reproductive life cycle that bring different risk-benefit considerations in terms of therapeutics in the context of pregnancy. What we want to discuss today is drug-drug interactions with contraceptives. We will discuss a little bit about teratogenicity, and we'll talk about birth outcomes mostly. What we won't discuss, and I'm happy to have a discussion afterwards, is the issues around breastfeeding, which are becoming increasingly more important. So let's first of all look at what happens to women in pregnancy. And this is the most recent data that was presented just a couple of months ago at the European AIDS Clinical Society. This is looking at pregnancy in the EuroSIDA cohort. The EuroSIDA is a large cohort of HIV-positive persons that has been collecting data for in excess of 15 years now. And in the EuroSIDA, 1,300 pregnancies were reported in 912 women, and of which 21% had data available. This is the demographics of where the pregnancies occurred, and you can see during this time period, almost 16 to 17% of women got pregnant at some stage. This is pregnancy outcomes, which was the most important data, and you can see that about 70% had live births, and so a decent outcome, of whom 3.3% gave birth to an HIV-positive infant. What was quite interesting about EuroSIDA was that HIV status was unknown or unreported in 47% of live births. Stillbirths were very infrequent, but spontaneous abortions occurred in about 10% of these women, with another 20% having medical abortions. And then looking at the adjusted odds ratio of live births, so potential risk factors for child mortality in this, you can see that in the top left-hand side, the period at which time the data was collected was very important. So in the context of pre-combination antiretroviral therapy or peri-combination antiretroviral therapy, there was a high risk of losing your baby. This also varied by region, and so some regions didn't do so well as others, and this was particularly true for Central and Eastern Europe. And then on the right-hand side, having hepatitis C was associated with an adverse outcome for the child. What about pregnancy outcomes amongst HIV-positive women in the era of universal antiretroviral therapy compared with HIV-negative women? So this is a recent study from Lesotho where they have a very good prevention of mother-to-child transmission program, and so all pregnant women who are tested HIV-positive get onto antiretroviral therapy on the option B+ program. And here you can see, comparing to HIV-negative women, there was a higher risk of any adverse pregnancy outcome of almost 2.5-fold, and that most of this was down to low birth weight and or intrauterine loss of the fetus. So when does mother-to-child transmission occur? You all know this data. You know that the vast majority of mother-to-child transmission occurs at around delivery or with breastfeeding, but there is a small risk of intrauterine transmissions as well. And so overall, mother-to-child transmission rates are between 15 to 30% without intervention, and up to 40% where infants are breastfed. The major risk factor for this is maternal HIV viral load, and this is some early data from the early days of experience of pregnancy and HIV, where you can see as the maternal viral load increases, the risk of mother-to-child transmission also increases, but that there isn't a viral load threshold below which no mother-to-child transmission occurs, and I think that's an important message to take away from this. So there is a history behind prevention of mother-to-child transmission in terms of drug regimens. We started in the olden days with the publication of the ACTG trials with option A, which was AZT for the mother during pregnancy, and a single dose nevarapine plus AZT and 3-TC at delivery and for a week postpartum. We then moved on to option B, that ART to mother only during the period of risk of mother-to-child transmission, and then continuation of ART only for those that met eligibility criteria for receiving antiretroviral therapy. And then option B+, which was first trialed in Malawi, is lifelong ART to all pregnant and breastfeeding women, and this has now become the option of choice because everybody with HIV should have antiretroviral therapy. And so lifelong ART benefits both the mother and the child. These are UNAIDS estimates in terms of receipt of option B+ antiretroviral therapy and prevention of mother-to-child transmission and the numbers of infections averted. And the UNAIDS estimates that in the time that we've rolled out ART in option B+, over 200,000 infections have been averted with a vast reduction in transmission from mother to child. What we're trying to do is to eliminate pediatric HIV by 2020, although we're far from it at this stage. This is some data from the UK. This is looking at UK transmission in women who are diagnosed HIV positive, and by 2016 we had gotten down to 0.28%, and if there were undetectable viral load throughout pregnancy, this was down to 0.17%. We still get a few mother-to-child transmissions, but they are often in the context of very highly complex social circumstances, including migration status, housing problems, and intimate partner violence. And so these are really difficult circumstances in which these women fall pregnant and then give birth. So 84% of low and middle income countries have now adopted a treat all policy by mid-2018. This is a map showing where it's been taken up, and maps of reds where there's still issues that need to be tackled. So let's now concentrate on pregnancy and the drugs. So you all know that there are a number of physiological effects of pregnancy that will have consequences for drug distribution and drug metabolism. So amongst things that you get in pregnancy are delayed gastric emptying and increased gastric pH, you get increased cardiac output, increased total body water and extracellular fluid, and in fact an increase in the fat compartment as well. There's also some alteration in your cytochrome P450 isoenzymes and UGT activity, and so all of these will have an impact on the way you metabolize and handle drugs during pregnancy. Unfortunately, there has been a long delay between licensing and getting adequate data on pregnancy dosing. This is a paper that's about to be published in Clinical Infectious Diseases, looking at the time interval between licensing of a drug and when detailed PK studies are available in pregnancy so that we can dose appropriately in pregnancy. I know that we had a question earlier about TAF and pregnancy. We still don't have enough data on TAF and pregnancy, although we suspect that it'll be fine in the context of pregnancy. So this is some recent data looking at L-vitagravir and cobicistat, and you can see on the left that the C24 concentrations of L-vitagravir are 80% lower in the second trimester and 90% lower in the third trimester, and similarly cobicistat levels are 60% lower in the second and 75% lower in the third trimester. So handling of cobicistat and its boosting of L-vitagravir is negatively impacted by the second and third trimester of pregnancy. Similarly, darunavir, especially if it's cobicistat boosted darunavir, has a similar effect in that there was 92% reduction of C-min in the second trimester and a 90% in the third trimester when it's boosted with cobicistat. When it's boosted with ritonavir, you can get away with this by twice daily dosing. So darunavir 600, 100 twice daily will overcome some of the negative impacts on darunavir alone of pregnancy. So these are some of the recommended and alternate starting art in pregnancy from the latest iteration of the British HIV Association guidelines. And so the backbones are very similar to the backbones that we use in standard practice, so bacavir, lamivudine, TDF, and emtricitabine. Zidovudine, lamivudine is an alternative because there's a lot of experience of its safety in pregnancy, but the recommended anchor agent is either efavirenz or boosted atazanavir because there is the longest experience of these two drugs. There are alternatives that have shown safety in pregnancy, including rilpivirine, twice daily darunavir, twice daily raltegravir, and dolutegravir, which we'll talk about in a little bit more detail in the context of neural tube defects in a bit. So what about integrase use in pregnancy? So let's just summarize this for you in one slide, and then we'll look at some raltegravir and dolutegravir data in a little bit more detail. So we've already seen the PK handling of L-vitagravir and cobicistat, and there's a hugely altered PK of cobicistat, especially in the second and third trimesters, and so this is not recommended to be used in pregnancy. Bictegravir, we have no data for just at this stage, and so we'll wait and see what happens to that in the future. For raltegravir, there is no data with once daily raltegravir, and so this is not currently recommended in pregnancy. If you're going to use raltegravir in pregnancy, and I'll show you some data with raltegravir, it's a very good drug to use, especially if people present in late pregnancy, then 400 milligrams twice a day is what's recommended. And then dolutegravir, we've got some data for, which I'll show you in a second. So the first study I wanted to bring up to you, and this is a very recent study. So this is a global randomized control trial to assess the safety and efficacy of raltegravir versus efavirenz in women after the first trimester of pregnancy. So this was about 200 in each arm that were randomized after the second trimester to receive either raltegravir twice daily based antiretroviral therapy or efavirenz based antiretroviral therapy. And this is just looking at their virological response at deliveries with a viral load cutoff of 200 copies per ml. And as you can see, overall, raltegravir seemed to perform better than efavirenz, but this was particularly true when women presented late, so after 28 weeks of gestation, where the difference was much bigger, and in both these instances, this was statistically significant. What was really interesting here, as we've seen before, is that the median time to an undetectable viral load at less than 200 was 8 days with raltegravir compared to 15 days with efavirenz, and so the rapid reduction in viral load was indeed helpful here. In terms of safety, there were no particular safety signals, although overall raltegravir was better tolerated than efavirenz, and that doesn't surprise you in any context. In terms of secondary safety endpoints, there were no differences. So there were no differences in terms of preterm delivery, and certainly no differences in terms of infant HIV infection, although numerically higher in the efavirenz-based arms compared to the raltegravir-based arms. So the other randomized control trial was the Dolphin-2 study, which was a randomized control trial in Uganda and South Africa, and this time looking at women presenting in the 3rd trimester of pregnancy needing to start antiretroviral therapy. And here we can see a very clear difference that across all strata, dolutegravir performed better than efavirenz because it was started so late in pregnancy. In terms of mother-to-child transmission, surprisingly, there were only 3 events of mother-to-child transmission, and all happened to be in the dolutegravir arm, and were all thought to be possibly infections in utero in the first 2 trimesters of pregnancy. And so all of this together suggests that at least dolutegravir and raltegravir are not only safe in pregnancy, but are also associated with rapid reductions in viral load, which may be an advantage in that context. So let's look at teratogenicity and risk to the fetus in terms of drug-induced effects. You all know this, but that the neural tube is probably fully developed by about 4 weeks of gestation, and by almost certainly 6 to 7 weeks after conception. And then the rest of the development is probably all complete by about 20 weeks, after which is limb growth and external genitalia that are implicated for by the drugs. So this is the Antiretroviral Pregnancy Register, which is run from the United States, but it collects data from all around the world in terms of pregnancy-related outcomes. The thing about the pregnancy registry is that it starts collecting data at conception, and so people report at conception, and then they report periodically afterwards. And you can see they have loads of experience with the NRTIs up here, with thousands of births recorded with very few neural tube defects. So the population prevalence of neural tube defects, certainly in North America, is around 0.1%. And you can see for most of these, it falls well below that. They also have some experience on integrase inhibitors, but the numbers are very small, and it is said that for a population prevalence of around 0.1% of a congenital defect, you need perhaps the experience of around 2,000 pregnancies to be able to have confidence intervals that will tell you whether the effect is in fact true or not. And so this was a study that caused a lot of stir last year. This was a CEPAMO study. The CEPAMO study is a national study in Botswana that was originally initiated in 2014 to assess the prevalence of neural tube defects amongst women receiving efavirenz at conception. The analysis then went on to include dolutegravir as the national program moved from efavirenz to dolutegravir. And in early 2018, they reported to the WHO an increase in neural tube defects on the women that had dolutegravir compared to efavirenz or other drugs. And this was dolutegravir at or before conception rather than started in 2nd or 3rd trimester of pregnancy. So this is an update of that data in July this year at the IAS. This is data collected to March 2019. And although still higher than any of the other groups, the incidence now is much lower. And so the neural tube defect up there is 0.3 relative risk compared to any non-dolutegravir containing ART and compared to being HIV negative. The confidence intervals cross the others, but these are still numerically higher numbers than we've seen with any other antiretroviral regimen or being HIV negative. And so in the current analyses, 0.3% dolutegravir versus 0.1% non-dolutegravir ART, estimated difference of between 0.2 to 0.27%. Based on the current findings, additional surveillance reports, the WHO then released a statement in terms of what to do with dolutegravir in national programs. And the WHO guidance was very straightforward, that dolutegravir can be prescribed for adult women and adolescent girls of childbearing age or potential who wish to become pregnant and who are not otherwise using or accessing consistent and effective contraception, as long as they have been fully informed of the potential increase in the risk of neural tube defects, and that this risk is probably over by the time you're beyond 6 weeks of pregnancy. So what are the recommendations from EACTS in terms of what to do with ART in women? If they are planning pregnancy or becoming pregnant on antiretroviral therapy, maintain ART unless regimen contraindicated. And like Beaver, they say that if somebody is planning pregnancy and are on dolutegravir, then they may wish to come off dolutegravir and go to an alternative regimen for at least the first trimester of pregnancy. If they're becoming pregnant and antiretroviral therapy naive, you need to start antiretroviral therapy as soon as possible. And if the follow-up starts late in second or third trimester, start antiretroviral therapy immediately and consider a raltegravir-based regimen to rapidly lower the HIV viral load. In terms of detectable viral load at third trimester, perform resistance testing, and if not receiving an integrase inhibitor, please start one immediately. They also recommend, like other guidelines, that there's no data on 1200 milligrams once daily of raltegravir, so it's not recommended, and that raltegravir 400 milligrams BD is fine, and efavirenz probably has the most data in terms of safety, and so a suitable alternative for starting treatment in pregnancy. So I'm going to stop there with a few take-home messages, is that ART is of benefit for both maternal health and prevention of mother-to-child transmission. Please be slightly wary of PK in pregnancy, and we will get more and more data with the new drugs. So just be slightly careful of what drugs your patients are on. The key is, if they're not on antiretroviral therapy, start immediately or as soon as feasible after the first trimester. And if they're on stable ART, only modify when necessary. And raltegravir and dolutegravir are particularly useful for late presentation in pregnancy. So I'll stop there. Thank you very much.